El seminario comenzará en breve. Por favor, permanezca en línea. La emisión está comenzando. Todos los asistentes están en modo de solo escucha.
Pediatrix Neonatology Grand Round Series hosted by the Pediatrics Center for Research, Education, Quality, and Safety. Before I pass it over to today's presenter, just a couple of quick housekeeping items. Within your GoToWebinar control panel, you'll find a handout containing the accreditation information for today's activity, including the relevant disclosures and objectives. In addition, following the presentation, please feel free to control. With this session, you were CE certificate from within the Pediatrics CE portal. Please feel free to email the CE team should you have any questions at continuing.education@pediatrics.com. We are delighted to have Dr. Annie, neonatologist and clinical ethicist, join us for today's Grand Rounds webinar. As mentioned, her brief biography can be found within the handout section within your GoToWebinar control panel. So without further ado, I'll pass the virtual mic over to Dr. Annie JANVIER to kick off.
When their baby is in the NICU. So I don't have any financial relationships or any money related to anything I'm talking about. When you study ethics, you don't have much money. But I have a personal disclosure is that I am myself the mom of 3 kids, one of which all who had medical problems at some point in their lives, but one of whom was born at 24 weeks and who is now 17 years old. So the objectives today is to understand the complexity of the parent-family experience and to identify opportunities for improvement in the NICU about how to communicate with families and to develop flexible care models. So all of you work in neonatology, most probably are clinicians there. And you know that unlike everywhere else in medicine, where most of the patient experience is trauma, there's also a lot of celebration in the NICU. And we can see that in Mary's eyes. So she doesn't only have the pain related to preterm birth and the grief and guilt or loss that are related to everything that she hoped would be of a healthy pregnancy and delivery and breastfeeding, but she always also has many celebration of learning to know her baby, some meaning, acceptance, the survival of her baby, and the connection that she feels with the baby. And we know that the NICU changes parents. In fact, there's almost half of the parents who go through an ICU who develop depression, post-traumatic stress disorder, are stressed, develop anxiety. So the NICU can be a pretty harmful place for parents, but it can also transform parents for the best. And there's more and more literature. We've just sent 2 more papers asking parents about their experience. This is the first one we sent where we ask parents the impact of prematurity, which makes parents more vulnerable, but also makes them stronger, have more gratitude, perspective about life, makes actually their relationships stronger and not necessarily weaker. Definitions of perfections change. So parents describe some strength with the vulnerability knowing who you are and what you can do and the resilience that you have. So how can we harness these positive transformation? How can we make the NICU a more positive place where we may have less PTSD and something more positive? And I'll focus on the positive because you can find psychologists, many people who have examined how to act on depression or act when we see pre-PTSD starting to happen. So at first, I'll speak about really the most essential groundwork on how to communicate with parents. And we wrote this ethics and etiquette in neonatal intensive care. It's a group of 20 authors. And we inspired ourselves from the etiquette-based medicine that Kahn published in 2008 in New England Journal of Medicine. He's an internist, and he said in his paper that I'm summarizing, I don't know why we're teaching all these eloquent things to clinicians because they can't even be decent human beings in the first place. They don't introduce themselves. Often they don't know the name of the patient. They don't tell the patient why they're there, ask them how they feel. And when they touch them, they don't ask for permission, often examine patient in front of 20 people during rounds, and they don't explain why they need to touch them. So he said in etiquette-based medicine, this is what you need to do in order just to be a decent human being. And then you can think about communicating with patients. So this article was amazing, but attract many comments and criticism saying this is so infantilizing. This is what we learn in preschool. This is what we all do. I don't know why you think doctors don't do this. This is patronizing. So he said, well, I'm not sure. And then his group looked at in an internal medicine floor in 2013, if these very basic things, like I'm Dr. JANVIER, I'm here to see Theo, I'm part of the neonatal team. How do you think he's feeling today? And I may examine his belly because he had several regurgitations. So what he's actually speaking about takes about So he concluded then, yes, for all those who thought I was infantilizing, etiquette-based medicine or the minimal behaviors you would think a doctor would have is infrequently practiced. So what we recommended in our article is, do we know the name of the baby before we go in the room? If parents are there to look at really essentials. And when we looked at this in our unit, we didn't publish this for a week. People thought it was very infantilizing, but how many times an RT goes in the room, changes the respirator, avoids to look at the parent? Or a gazillion consultants come, or residents or students or fellows and any specialty come in, examine the belly and just say hi bye to parents. It's actually pretty surprising. So now, beyond the very basic of saying your name and knowing the name of the baby, there's actually ways in pediatrics, especially Chris Feutner and all his group in CHOP, that have developed ways to increase the parental sense of competence and all the positive, the celebration that we can also have as parents in a hospital. And how can we increase this parent sense of competence? Because it is associated with parental presence, with parental satisfaction. So there's some scales that exist to measure this, but Chris Feutner, if you haven't read his things, write his name down, and you can, any of his 400 articles are amazing. He's a wonderful palliative care researcher and clinician. And he's asked parents what it meant for them to be a good parent, and reinforcing these parent beliefs was something that was positive. And by very sentences that look naively not very compromising, but that can harm families. And I'll give you examples of in the rest of the presentation on how to help parents feel like good parents, not feel like bad parents, and at least feel like parents. So all the quotes that you will see in this presentation comes from the research we've done with families, and our examples or bad examples on what to do to make a parent feel good and empower the parent, or feel bad and cause harm. So how can we address the guilt? I think I say this every time almost I enter in a room. As a good parent, we always think about what we could have done to prevent what's happening. There's nothing you you could have done to prevent what's happening to your baby. It could be about prematurity, it could be about neck, and to be honest, in neonatology, it's actually very rare that parents do things that cause prematurity. Doctors sometimes take 2 or 3 embryos, but parents generally 95% of the time did not cause prematurity. An example on how we can promote, but not promote it in a harmful way, but say many parents when they arrive here feel stressed. Some tell us they don't feel like parents. This is normal at the beginning, but it will change and we'll be with you all the way. So actually to acknowledge that some parents don't feel like parents is very helpful for families. Another example that a parent told us that was very helpful for her, all the alarms and machine that a nurse told her, all the alarms and machine can be stressful. Some parents told us they were afraid to visit. It's normal to feel like this at first. We will be there to support you. It will get better. So acknowledging that it's difficult, but that we will be there and it won't always be like this is something useful. Examples that harmed parents. And harmed parents, those who didn't like skin-to-skin care. There's many parents out there that are very anxious at first, that don't enjoy their first experiences. And when they're told by nurses, you will love kangaroo care, for example, this sentence was to be the worst thing she has heard through her whole NICU stay. She said, I was afraid to be there. I didn't want to come. I was afraid to hold my baby. I didn't feel like a mom. The nurse told me I would love it. I hated it. I wasn't a good parent, didn't feel like one, made me feel even worse. So rather you can read the alternate sentence that another parent identified as very useful. Beware too of the congratulations. When parents get in the unit, they have often a sense of guilt and incompetence, and to congratulate them, it helps some parents, but it really harms others. So it's not like, congratulations for your cute baby, you know, who's on hi-fi and looking like a tiny micro human being that the parents have a hard time relating to is not always something that is felt positively. These are examples of sentences that were reported by parents as being the best that they had heard in their whole NICU stay. This is when we asked parents who had been in the unit for 2 months about important parent beliefs and how they felt like parents, what nurses, doctors, any clinician told them. And you will see that everything is empowering to see, like the baby's lucky to have a parent like them. The parents are being part of the team and doing important things clinicians can't do. So for example, while Mathieu is 1 month old, this means he has been receiving your milk for 1 month. You are a superwoman. This protects his life and got better than anything we can do. So that mother's like, great, you know, I'm going to continue breastfeeding. I'm important. I'm coming. I'm doing something for my baby. And they think I'm useful. So these are examples that were reported as the best sentences they heard. Now, if we look at beyond just communication and making parents feel like parents, try to decrease the guilt and try to communicate better, family integrated care is a caring model that can improve how we relate to families, how we communicate with them, how we make them part of the team. And we know that the philosophy of care has changed in neonatology. I remember even as a resident, there was like, I guess more than 20 years ago, parents couldn't come at all times. Kangaroo was very complicated. It was for stable babies on CPAP and care, really integrated visited in Uppsala in Sweden, and I was the guest editor for an issue on babies less than 25 weeks, and I've asked nursing there, the clinician who's in the parent support team, to publish an article, and these are pictures from the article. So you can see here the 6-year-old munching away on a cookie, watching a video while the baby who's on the respirator intubated is on the dad who's actually having a nap there. Like, our infection control would go berserk looking at that picture. But this is the way it is in Uppsala. The family moves there, the kid integrates a school close by, and the family actually lives in the NICU. They have Cracker Jacks, milk, their fridge, and all this stuff. So it's actually inspiring, and for me, to be honest, a bit weird when I visited the unit, because I couldn't imagine how this could work in our unit. These are other pictures from this article of parents being there to do x-rays. So they're trained to be the x-ray, who stabilize the baby, get the leads off, get him straight. They learn how to do it. The intubated baby's on the mom. They're almost in kangaroo care all day, but the baby's on the mom while the IV's being changed. And they also put PICC lines on parents and chest tubes and things like that. And for many of these things, there's no clear, rigorous evidence that it's beneficial, although sometimes if it's been happening for years, it's very hard to say, oh, we'll stop integrating parents and we'll integrate half the parents in the unit and see if it works. And I'll give you an example of, for example, the single patient family room. This has started to be the norm because of concerns of noise, of all the parents together. And in fact, if you look at publications that came after the single patient room, because we're trying to avoid the huge, all the patients in the same room, we can see it decreases infections and noise. It increases parental presence on average, not for all patients. Some patients, they're sorely alone in their room. But then we have other articles that come out that show that there's less meaningful noise. It's associated with worse language outcomes for certain patients. That's the Terry Enders group. There's more maternal isolation in the room. They can't speak to other people or hear what's going on or have small chat. Increased maternal stress in the first month. And it also decreases nursing mentorship and the time nurses spend with families. And one of these articles reports that the parents need to want to come at the bedside for this model to work. So family integrated care, also now called FI care, in the articles is becoming the norm. So O'Brien and their group published in 2018 a family integrated care model where parents were integrated in the team. And it improved breastfeeding rates, parental anxiety, and depression. The thing is, the inclusion criteria is that in order to enter the study, parents had to be there a minimum of 8 hours every day. And we know that if a parent's there 8 hours every day, these outcomes improve. And so after the FI care model, the one published in the Lancet came out, there's many QI projects that I see because I'm interested in this. So when I go at a conference, I look at these posters, and there's many QI projects with the goal that 60 to 80% of parents, for example, will present their baby at clinical rounds, or there during interventions, for example, intubations, tube feed their baby, verify IV site, do skin-to-skin care in the first 2 hours after birth. So there's many things projects that inspire themselves from that model to say, where can we get better? So in our hospital, we have a large PAFITS partnership with families group, and there's 35 parents who work with us, an interdisciplinary group. We're 10 of all professions. When it was the time to actually join the FI care study, the vote was almost unanimous not to be part of the FI care research, because we thought, why would we improve you know, the fate of parents who are there 8 hours during the day. What we're trying to do is actually improve those who cannot be there for 8 hours. And in the FICARE agenda of what the parents had to do or team up to do and become able to do, passionate people who all love family integrated care and families, including families, disagreed. Some parents thought they would never want to change oxygen. Others said, yes, I would love to do this. So because of the disagreement, it was like clearly we didn't participate in a study, but then it was very much less clear, how can we develop our unit? So we decided to do this QI project. And it became an article about the ethics of family integrated care, because you'll see that parents are very different in what they want to do. So we wanted to look at the perspectives of all stakeholders and implement changes that were meaningful and important. And in the end, it was those that were also easy to implement, as opposed to extremely complicated and created more conflict than good. So for 3 months, we approached everybody working in the NICU. I mean, from social workers, residents, neonatologists, nurses, all the professionals, clerks. And we asked parents who were in the unit for a month. We also approached parents at the follow-up visit more than a year after discharge to see if parents that had gone through the experience or were going through the experience would say the same thing. They mostly said the same thing. The questionnaire was co-constructed by our team of PATH 35 parents and 10 providers. And for each, we had a really long list of anything a parent could do in the NICU. And for each question, each item, we asked in the NICU at the present time, can parents do this if they wish to? And ideally, should parents be able, if they want to do that? So I'll give you an example. Well, it's in French, but on the unit at the moment, I could have put the one in English because it was translated, because some people speak English in Quebec. So on the unit at the moment, and ideally the parent should be able to whatever. So it's from giving the bath to hold the baby during an LP. And this is only one of 3 sheets of all of what parents could do. Then we asked an open-ended question of, please tell us how we can optimize integration of parents in the unit. So we had 331 participants, 102 parents, and a big array of different kind of parents with twins with congenital anomalies, some who had surgery. So for the results, for many basic care items, almost all participants answered FICARE occurred in the NICU and should be standard of care. So for example, you can see here, giving the bath, they say, yes, of course, parents can do this. And ideally, yes, parents could do this. So there's a big concordance that when parents or the participants answered yes, they put yes in the other column. So you see the whole list there: read to the baby, sing to the baby, be there at vaccination, express their opinion, be there at rounds, ask questions during rounds, participate in plans of care. It was unanimous. It was 98% plus who answered yes and yes. Interestingly, you can read the article for the whole list, but for more medical items, parents were all different. Interestingly, physicians were not different. Residents, fellows, neonatologists, they all wanted more FICARE. So for example, the majority of physicians, like more than 80%, anything it had to do with medical care, they wanted more parent involvement, generally more than other clinicians. So they just said, no, parents, do not change the oxygen. Yes, parents should change the oxygen. No, parents, do not check the IV. Yes, parents should check the IV. No, parents, like no and yes. But when we looked at parents, 42% of parents did not want to tube feed their child. They said, no, parents don't want to do, I don't want to do it. I can't do it, I don't want to do it. There's still 60% who said, I can't do it, I want to do it. And we only teach parents to tube feed if they will tube feed their child after discharge in our unit. About half the parents did not want to present their child at rounds. which is interesting because we ask the parents what they think, if they want to say what's bothering them, if they think one plan is best than the other, do they want to participate? And not all of them participate. But we can see that almost half, they don't want to do this. And half the parents don't want to be there at resuscitations. Unlike what parents said, it's about half-half for all the medical things. 85% of physicians think parents should be there versus 30% of nurses. The nurses were way more aligned with what parents wanted than what physicians thought we should do by integrating parents. There was many good things that parents identified in the open-ended question that were important features of FI care, and they are all related to feeling like being a good parent. For example, a mom who said, I really enjoy doing these things. It made me feel like a real mother first, and then at some point, like a good mother. I have failed my birth, but I can help her heal and be in charge of it. And you can see all the comments go, for example, this dad who said, it helped me become a father for real. Or a mom who wrote, he's supposed to be inside me at the moment. My uterus is supposed to do all these things, not machines. When I give him this kind of attention, I get this closeness back, the sense that I'm doing my job. But several parents really identified downsides and feeling guilt and being harmed by some of the things that we tried to make them do, or they felt that they were pressured to do some things. And this is why FI care sometimes may feel like family imposed care. Such as this mother who said every day a nice nurse would ask me if I would come back in the evening. I had 2 other small children at home who reacted to my absence and an exhausted husband. So I ended up every night either crying at home, missing my baby, or crying in the NICU, missing my other kids. Family integrated care occurs at home too. I wish they understood. Sometimes just asking us hurts. Another dad said, I don't know, this is not what I see myself doing as a parent, like inserting a tube myself so my baby can eat. This is a medical thing and I want to be a dad. The goal is that she will go home without these tubes. So I really want to focus on being there with her, not learn to become a nurse. And I'll just share a personal anecdote. This is when Violette, my daughter, was 24 hours old. The nurses were adamant, because at that point it was the festival of trying to be the good parent-centered care place, where I was part of the team. And I had been part of that team that we were trying to have moms do kangaroo in the first 24 to 48 hours. And when I went to see her, I mean, I'm a neonatologist, I can intubate 24 weeks and do whatever is needed. I really did not want to hold this baby who was actually really unstable with ET tube only at 4.5 centimeters. And I didn't want to hold her. So they were adamant that I do. So they changed her incubator on purpose to make me hold her while they brought a new incubator that was apparently clean to put her in. And this was one of the most traumatic times that I had in the NICU because I was clearly not ready. I didn't want to do this. I was forced to. And for the month after, I only visited at change of shift to make sure that nobody would have time to give me my daughter. So reading some of these, it resonated in me, but I can assure you I'm reporting what is in my studies and not just my personal experience, but there's some of these sentences that were very real for me. In answers to open-ended questions, there were many, many, many positive things. I'm not trying to tell you today that family integrated is not good. It brought a lot of positive things. 82% of parents wanted to meet also other parents. They said, we don't have access to stories. Can we meet older parents? Can we network together on the unit? This would help us. Parents really appreciated clinicians. They were generally happy with what was going on. They really thanked the nurses. They loved the nurses. Actually, they thanked the nurses way more than the other clinicians. Clinicians all want to help parents more. Physicians are totally gung-ho for more FI care everywhere. Half the nurses wanted to increase parent participation. And I say but because there was a general positive, but half the nurses were critical towards FICARE initiatives, especially when they were medical. For example, parents holding during the LP, holding the kid during x-rays, checking the IV site, changing the oxygen, tube feeding the baby. And when explaining the reservations, several themes were invoked: the responsibility of the nurse and the role of parents. So one nurse said, this is my patient and it's their baby. It's not their responsibility to do those things, such as hold baby for LPs, 2 exclamation marks. You were allowed to answer the questionnaire writing or on the computer. So she wrote, they should do the caring parts. Parents do change diaper, kangaroo, be parents. Others, you can read what they reported. I did not do a nursing degree for parents to do my job. There are just not things parents do. It's not safe and will cause stress on many mothers. But we can see what they're saying is what half the parents are saying though, but there's half of parents who don't say that. The biggest irritant for parents was the variation of care in nursing practice. Parents felt judged and harmed when this happened, and this leads to polarization of the good versus the bad nurse. We saw these comments for RTs, but honestly, there's only 2 parents who spoke about variation in medical practice, whereas this is what we hear all the time at conferences. The 2 things that harm parents the most is opinions that were different for kangaroo care, skin to skin, and opinions that were different about feeding, nutrition, breastfeeding, bottles, tubes. And you can see one of the examples. The day nurse tells me my son is too fragile for a kangaroo. And after the change of shift, the evening nurse asks me why we didn't do kangaroo today, that it's good for Ludo. What? I was here all day. Who is the bad nurse there? Is one too scared and junior? Is the other one too cowboy and dangerous? I don't know if that's an expression, being a cowboy in English, but it is in French. What I find is the hardest at the moment, this was a mom who was there for 2 months, no, 3 months already. The baby was born around 24, 25 weeks, is to have different opinions on how much I should come here to breastfeed, what they think of bottles because my milk is not sufficient, and when I should place her on the breast. It makes me feel so incompetent. I'm so mixed up. I don't know who to believe. So what did we do in our unit? We worked on the areas where parents were most dissatisfied and the team is least resistant to change. So parents said they didn't have enough information. The discharge was appalling. It's becoming mediocre. It's actually very hard to work and discharge. The variations in nursing practice, that was easy. We actually developed protocols for feeding, for cube feeding, for kangaroo, for many things. And resource parents, so you call them veteran parents, were introduced, and peer-to-peer support started in our unit and in the high-risk prenatal unit. We waited to implement what was not as important to parents and where there's a high resistance to change from the nurses. So parents giving tube feeds, monitoring IV sites, and changing oxygen. And we speak to parents differently about their preferences for more medical items. For example, presence during interventions, which parents are invited to stay during medical interventions in the unit. And this is one of the sentences that has changed my practice. It's the mother of a baby born at 25 weeks that wrote that. And I actually use this in practice now. Some parents, other parents, every day I'm on service. So what she wrote is, just asking, do you want to be there during the intubation makes me think that I need to be there, that this is what good parents do, and I want to be a good mother or show them I'm good. What kind of parents want to leave their child when asked if they want to stay? If there's no good answer, they should say something like, some parents want to be there during the intubation. It makes them feel in control. For these parents, imagining is worse than seeing. For other parents, it's different. Seeing an intubation on their child is too stressful and it does not help them or their family. What kind of parent are you? And if you remember one thing of this talk, it's some parents, other parents. And I use that. Some parents want a lot of information. Other parents want the big picture. What kind of parent are you? Some parents want to decide on their own. Other parents want this. This is very useful because when asked, Do you want information? It's very hard for parents to say no. They say yes, then they don't listen to you if they don't want the information. So some parents has been taught in our unit, and I think it helps families. For information for parents, we have Ombrelle is a support group in the high-risk pregnancy floor that is in hybrid mode now. So all the moms on the high risk get together, but all those who are home join us. And we speak about neonatology, about guilt, about being a parent, about dealing with high-risk pregnancies, grief, things like this. We have the welcome in the neonatal team that was actually written by parents mostly, or 35 parents, what they thought was important with us, and has pictures of who's part of the team and what's what. There's also a video of a visit of the unit where clinicians and parents, for new parents that can't visit the unit that are on bed rest or with like the COVID festival, weren't able to come and visit the unit, can actually view the video that shows them how the single rooms look like and what rounds is, and it's like a 7-minute video. Parents wanted, or this is an example of really good art by Red Métat. Red Métat is a Quebecer, and his name is Red because he was born at 28 weeks. He's about 30 right now. And his mom was so shocked when she saw him, and she didn't know what to call him. So she called him Red because he was so red. And it's his real name. And Red Métat was sick of seeing all the bad press for preemies. And several years ago, decided to do in his art, he's a photographer, les prématurés. And you'll see these are just examples of for preterm. And he was very integrated a lot of patients, all the patients. He didn't want only, the preemie that climbs the Kilimanjaro or is like super good at math. He chose all preemies of a whole year and pictured them. I took a picture of them. So you can see here, this baby was born at 23 weeks. It has many complex needs, like he can't stand up for the picture, and he's got oxygen. You also see here, he had a twin, and his twin died. So the twin is also in the picture. And you have actually a representation, but an artful human representation of the NICU. Parents wanted story of other families, so we had the Redem come and expose his pictures and have pictures in our unit, but we also developed another mosaic with many pictures and videos of parents telling their story. And we try to be representative too. So we have some twins that are discordant in death. We have a child who died. We have 2 who had gastrostomy later on. And we have the generic normal the nice story of the 32-weeker who's my sister's baby. So we can actually have preterms that are healthy in our family. But you have a lot of stories of different kind of outcomes. That is outside and that is coupled by videos if parents scan the QR code. We've also integrated resource parents, asked parents what they would like to speak about with new parents, and it's guilt, the feeling of failure as a parent, what you can do, how to harness resilience, how the unit is, and sharing together is actually useful. And in this article, if you want to start this is the experience of starting this. For example, if you call it a support group, no dads come, and there's much less people than if you call it a workshop. If there's food, more people come. We're not allowed to have now some because of COVID, but when there's food, there's twice as many people. So there's several things. We tried different formats and saw what was working better. We develop workshops with families. This is again by asking them what they would want to speak about as parent groups. And being a parent in the NICU was the first one, but they wanted a workshop on organization and money, how to apply for parental leave. Us, it's very weird because, well, it's not weird, it's good. We have a year parental leave, but the parental leave can start when the baby starts the unit, and then you need to decide if you're proche aidant or in parental leave, and it can be shared between mom and dad, and then it depends which job they do to optimize their money. So it's very complicated to apply and decide what to do, so they get as a group, and the social worker helps them. And you can see the other one, breastfeeding, transfer to intermediate care was judged as being one of the most stressful things for parents. So we did a workshop like this, one on discharge and one on breathing. And these workshops, when we asked parents after them what was helpful, what was not helpful, what we could do to improve, were really good for parents, mainly to decrease isolation and to give them hope. And you can read what one of the mothers have said, who had lost a twin, and said, seeing is believing, that when she was in a room with a resource parent who had lost 2 of her triplets, and realized that all parents in that room have lost something. And I'll read it, it's better. Even when we speak to the psychologists, it's not the same thing. The groups make it clear I can really be okay in the end, that real life can come back, that it will not always be like this. We just feel stronger. Others made it through. We are together, and we will too. So the sharing of stories for families is important. And there's many, many interventions here. I really very egoistically spoke about my research, but there's tons of research like mindfulness during kangaroo, yoga for families, massage for parents, parent navigator app on the cell phone, other kinds of support groups for parents, buddy systems, coping kit, beads of courage. Coping kit is Chris's new thing that's amazing, Chris Feutner. Beads of courage, there's a lot of things. There's also unpublished but amazing programs. When I go somewhere to talk, I want to speak to their parent group and ask the nurses what they do. I was so surprised in Philadelphia, the philosopher who did Fathers Who Knit, and could get the fathers in the unit to come and knit. And actually, while they were knitting and not looking at each other, were speaking about the most important things to them. There's boxing room, lavender rooms, free gym memberships that are done in some units. And most of these studies, like mine, have a lack of robust evidence because it's not a randomized trial in 1,000 parents. And in most of these studies, less than half the parents participate. So in our peer-to-peer groups, those who didn't come, we actually asked them, why didn't you come? And some said, I'm not a group person. I get support elsewhere. And I think it's okay, like parents are all different. And that's the problem with these studies, is that if you only help 30% of parents in the way that is best to help them, many quantitative measures are very hard to apply because they may not be depressed, but it actually increased breastfeeding for a mom, but another is gung-ho on breastfeeding and it may decrease the trauma she feels. So a goal, in my opinion, is a catalog of interventions, and tell parents, try each of them, and you may be surprised of what you'll like and not like. So I'll finish the talk with, the ideas you could have for your unit, keeping in mind that all units are different. If you're next to a track, you can get parents to run in front or walk. If you're next to a pool, it's different. If you have somebody who's an artist and works as a nurse, they can actually start painting on the wall or on little tiles that they can then bring home. So there's a lot of things that are unit specific. What are the best solution? What to check and measure, keeping in mind potential harm. So some parents report experiencing guilt from feeling non-optimal involvement. And I personally would avoid QI goals such as 80% of mom feed from the breast, or 80% of parents present at rounds, 80% are there during the resuscitation, or hold their baby in kangaroo care in the first 2 hours, because I think this can help, but it can also harm the parents who need the most help. And the changes need to respect the reality of each NICU. So we can't have kids who eat crackers on beds, for example. And this will be affected by social and family characteristics, such as a parental leave of a year is really good because the mom is able to come. And when I go in specific units and I'm asked for my opinion, I often tell the team there to choose their battles and do what's easier. So I remember a team that was working so hard for parents to present at rounds when there's no parental leave in their state and the parking is $20. And yes, you can mobilize yourself to change this. But during their rounds, they were all rounding, 20 of them in this huge multidisciplinary rounds you have in the US because there's so many people. Everybody had their computer, was above the parent, spoke together, rarely engaged the parents. And I said, if you leave your computers outside and twice a week you do non-multi rounds where you're 3 people sitting down, they'll probably meet much better and super easier to do than to actually have parents present at rounds. But this is like system changes. Are there chair in the single rooms? Do residence consultants enter whenever they want to examine a baby? So there's a lot of things we can improve. So the take-home message is the NICU is a place of trauma and celebration. NICU families also experience positive transformations, and we can harness this. We can support parenthood and helping parents feel like good parents. And careful implementation of family integrated care models are promising, but every NICU is different. And resource parents can help NICU parents if integrated in a clever way. This is like the best picture of Red Method because it's my daughter. And if you liked my talk, you'll probably like my book and you can actually call me for questions. Or ask the questions right now. I'll just close I'm supposed to appear on the screen at this point, and Reese is supposed to come too.
Yep, there you go. So we're open for questions now. Let's see if we've got any here coming up. Okay, yeah. So first one is, I wonder about your thoughts on integrated parent care surrounding procedures in a teaching hospital. For example, an LP and intubations where you have a learner involved. Does the parent's presence disrupt that learning or not? And I'll just add that while I agree that you want parents to be engaged as they feel appropriate, the parent room always made me a little bit more anxious about any procedure I was doing. So I think it's directed at learners doing an intubation more than you or I that have clinical experience and can talk them through exactly what we're doing. What are your thoughts?
So we have tiny baby intubation groups. So if you're intubate a baby less than 28 weeks, you need 10 intubations and 3 ones that are successful. So the success rate is 80% in our intubations. The R1s too, you call them PPY, intubate with a video laryngoscope. This is Ahmed Moussa's work of randomizing them to different routes of intubation. And parents are invited to stay because the success rate is high because there's directed teaching. And we told parents, we are a teaching hospital, the R1 will be there, the fellow's there, you can leave the room or stay. And half of them, I have to say, when you say some parents, other parents leave the room, but half of them stay. And if we want to do this family integrated care, I mean, we need to have residents become accustomed to it. Because many nurses would rather work in a room where there's no parents, or many staff would rather round when the parents are not there because it's quicker, it's more efficient. So we have to start somewhere, even if it makes us uncomfortable. But we do have a family baby team. There's always a superior looking at supervising the intubation, and the success rate is rather high.
So the next is an affirmation from Kaylee Hurt that says, "This is so wonderful. Thank you taking so much information back to our unit. As a parent on staff in our unit, this is so validating and encouraging that this work is being done elsewhere." Wonderful work. You know, one of the other things, I'll ask a question while we're waiting to see if there are other questions. You know, I think the listening is so important. I think you've done a great job in educating us with your work on knowing the baby's name, sitting down, and those things. And I have to say, I tend to talk too much. I think you know that from just having met me in a couple different meetings. So it's really hard for me to sit down and let the silence be there. So I tell myself in my head, show up, shut up, and listen, and sit down. So I think if we don't listen, we answer the wrong question, right? We don't really know what their question, but as you've done your research, what characteristics of listening have you found to be the most important?
So, and you're totally right, Reese, and I should have, and I blabbered for 15 minutes and I couldn't listen to anybody because I'm on a screen in my home on my own. Listening is extremely important. So in 2 of our articles, if we could shut up for 30 seconds, we were viewed as better doctors. Unanimously. If you shut up and sit down, you're 85% an amazing doctor by 85% of parents. Just shutting up and sitting down, shutting up 30 seconds. 30 seconds is actually long. And in our palliative care, so babies when we speak about life and death, this is especially important, the not speaking. And not speaking after questions such as, what scares you the most? Is there anything we can do for you? And sometimes it takes a long time after the parents start crying. Sometimes it takes a minute, and not saying anything for a minute for some of our residents and fellows, they say it's the hardest thing I've done in my week. I had to sit there, be super uncomfortable. The mom started crying. She wasn't speaking. I gave her a Kleenex. So when we actually studied this also in clinicians, it's not easy. So you're right that I try to say the 30-second rules to my residents, and it's actually not easy to say, how do you find Thomas? If the baby's just on CPAP full feeds, generally you have the answer quickly. If it's not going well, or if you ask questions such as what scares you the most, it may lead to uncomfortable feelings by clinicians.
So we've got another group of comments on, most of them are applauding. I think you're getting a standing ovation on a WebEx from different people. I gained so much insight. Thank you for your research. Let me see if there's a question here. I agree with this comment. I looked over your slides before talking, and I watched them again and listened to your talk. She says, I'm working to change our practice on how we interact with parents. I was guilty too of forcing kangaroo care too early. I will never do that again. That was something. Because I'm not generally the person asking that question, I hadn't thought through carefully, but you made that point very well, and I think it's important that we make assumptions. I think the worst assumption that I've found myself to make is, well, the child just has some hyperbilirubinemia, of course we're going to be fine. But to that parent who's coming in to be put under this bright blue light, it's a whole different ball game. And reminding myself to, hey, look at it from their perspective if you can, and you never really can, obviously, right? As a neonatologist and as a parent of a child who came through the NICU, that those two experiences are diametrically opposed in terms of how you interpret or feel things. So that was a learning point. Do you have any other comments on that before I go to the next one?
No, but it's true. I think normalizing emotions. And when I say my guilt sentence, many parents feel like they could have prevented something. There's nothing you could have done. 2/3 of moms cry hysterically. And a third said, no, I don't feel like that. So at least, it helped those who probably think they do it wrong. And saying some moms don't feel comfortable doing kangaroo care, and they will say, no, I'm waiting for this but at least if they heard that and they say, oh, I'm stressed, I don't want to come, I feel like a bad mom, you say, no, well, we'll try together. Tell us when you're ready. I'll be there with you. It's normal to feel like you are. And surprisingly, what you were saying about a 33-weeker on CPAP and 21% O2 full feed is super not sick for us neonatologists. But some parents actually think their baby will die, like my colleague Antoine Payot, that you call Antoine Payot for those who want to recognize him, has asked parents if they're stressed, and many think the kids will die. So now we actually say that. If you're scared your kid is dying, no, he's not. Your kid is super stable. He's one of the most stable and healthy babies in our unit. And parents, oh my God, a lot of them are extremely grateful to hear this.
So one of the questions is, can you speak a little bit more to how yoga programs can be developed for NICU parents, and what's your experience with it?
I forgot if that person can write me. There's a neonatologist who's a yoga teacher, and she's a trialist. She's now, I just have a brain fart. She's actually pretty well known in the world of neonatology. And she's developed yoga, and then she's developed videos, and you go from one video to the next. And it's like mom transformation as well as baby transformation. It's really well organized. And she's actually doing research on this. And I don't want to say the misidentify that woman, and I can send you her email, because she is developing this in her unit, and I heard her speak, but she has actually, because she's a trialist, wants to trial this. So it'll be interesting to see what she shows.
Another positive comment and question from one of your co-authors, Dan Ellsbury. Nice talk, Annie. We are seeing an increased number of parents that are hesitant or resistant, non-trusting of medical care. How do you effectively approach these families?
Resistant to which medical care?
Vaccines and vitamin K are the two big things that we're seeing.
So what we do for vitamin K, breast milk, we do the opt-out approach. Like what they do for HIV testing that was recommended by some policy statements is to say, we test for HIV and everybody, you're pregnant, so we test for HIV just because. Or the same thing they do now that's recommended in the ER for pregnancy testing. You actually test everybody that comes and vomits. And you say, you're vomiting, so we're testing you. We don't want even to. So it's the same thing we do for actual, not vaccinations, for vitamin D, for breast milk, for vitamin K. This is what we're doing. For vaccination, kids are older.